Hi, welcome to this session on what's new from the European Society of Cardiology Guidelines 2021. And although Milton Packer may not think much of this presentation, as you previously heard, I think we have some great speakers. We have some great moderators too. So let's try and make the most out of our wonderful speakers. So first of all, John McMurray will speak to us on what's new in medical treatment for heart failure patients in the new ESC guidelines. Please, John, it's a pleasure.
Thank you, Dr. Costello. I'm very intrigued by that comment about Milton Packer. You have to tell me about that afterwards. So my job is to try and give you an outline, an update on the new ESC guidelines, and also mention something else very important from that Congress. So these are my disclosures, and these are guidelines. They're enormous, 128 pages. There is a slide set to accompany them that is 118 slides. Imagine if I tried to show you 118 slides today, you wouldn't be very happy. So I'm going to be very selective in what I talk about. So this is a table right at the front of the guidelines that emphasizes what the committee thought were some new concepts, really the important things in the guidelines. And I'll go through some of these because I think that's maybe the most interesting place to start. So one of the new things in the guideline is a simplified algorithm for the treatment of patients with heart failure and reduced ejection fraction. And this is that algorithm. So it's a lot smaller than the previous one. It's not so vertical. And you can see here at the top of the algorithm are the recommended therapies for everybody. So green means class 1, recommended. And then you can see devices with either class 1 or class 2, a recommendation after the use of drug therapy in people who have a persistently low ejection fraction and maybe some ECG abnormalities as well. But what's really important in this new algorithm, the principal change in the new algorithm is that you see here dapagliflozin and empagliflozin, two SGLT2 inhibitors mentioned. The reason they're there, recommended as one of the core therapies for HFrEF, is because of these two trials, one with each of the two drugs in this new class. Here you see the results of those trials. So this is the same composite outcome and same y-axis. And here you see the hazard ratio, 25% relative risk reduction in this primary composite endpoint, this very rapid onset of benefit in each of these two trials. This not only large relative risk reduction, but large absolute risk reduction, excuse me, here expressed as a number needed to treat of only 21. Now, because we've only got 15 minutes, I can't go into all the details of why these drugs were strongly recommended in the guidelines, but it was really about the consistency of benefits. So the two trials, as I just shown you, had showed almost the identical effect of therapy in the primary composite endpoint. But it was more than that. There was a reduction in the two trials collectively in mortality, a reduction in symptoms, and even a reduction in the rate of decline in eGFR and deterioration in kidney function over time. So these two trials actually resulted in a class 1 level A. That's the strongest recommendation any treatment can get. And this new treatment went straight into that table in the 2021 guidelines. Now, I should mention that there's one other recommendation that isn't in the table, but I think is also an important advance in our thinking about therapeutics. And that is that now the guidelines say that we can use an angiotensin receptor neprilysin inhibitor as first-line treatment and not necessarily only after we've tried an ACE inhibitor or A or B. One of the other things mentioned in this table highlighting the sort of new concepts, new approaches in the guideline is the mention of an additional algorithm that really identifies the use of treatments, both drug, device, and interventional therapies according to patient phenotype. Probably a little bit hard to read, but I think it's a useful table. So, for example, if you look at patients who've got heart failure with reduced ejection fraction in sinus rhythm, but have a persistently high heart rate despite treatment with a beta blocker, which is up here at the top, these core therapies to reduce mortality, then there is an indication to use ivabradine. Now, we've known that for some time, but this new algorithm, I think, makes the targeting of these treatments, tailoring of these treatments to a particular patient phenotype a bit more visible. The actual recommendations for these drugs haven't really changed. These well-known therapies really have the same recommendation that they had previously. There is one new treatment in addition to SGLT2 inhibitors in the guidelines for the treatment of HFrEF, and that's a drug called vericiguat. It's a soluble guanylate cyclase stimulator. As you can see here, it didn't get a very strong recommendation, class 2B, so may be considered level B evidence. This is a drug that stimulates an intracellular enzyme that leads to an increase in production of it was tested in a large trial called Victoria that enrolled very high-risk patients, very high risk on the basis of both being recently hospitalized and having a very high NT-proBNP level. And overall, this trial was a little disappointing in that the relative risk reduction was rather modest, 10% relative risk reduction. And the reduction in risk of this composite outcome was driven by reduction in risk of heart failure hospitalization and not reduction in mortality. So that's why this got a less strong recommendation than SGLT2 inhibitors. And indeed, this drug, as far as I know, is still only recommended in the United States. So the guideline is maybe a bit ahead of the availability of this particular treatment in Europe. What else is in the guideline that I think stands out? Actually, the very first thing in this table of new concepts, new approaches, is about heart failure with what was previously called mid-range ejection fraction and is now called heart failure, renamed as heart failure with mildly reduced ejection fraction. Now, why was this renamed? Well, there are two reasons. One is that as we've learned more about these patients with an ejection fraction that's below normal, but not in the clearly reduced range, when you look at their characteristics, they resemble patients with HFrEF than they do patients with a more normal ejection fraction. And secondly, these patients seem to respond favorably to the treatments that we know work in patients with heart failure and reduced ejection fraction. And we've really established this from a number of admittedly retrospective analyses of previous trials. So if you look here, for example, at the CHARM program, this is a continuous hazard ratio. It is below 1, above an ejection fraction of 40. So there is benefit here, perhaps as far up as an ejection fraction of 60. And this has been a consistent finding with the other treatments that we've looked at. So in the new guideline, as you can see here, most of these treatments got a class 2B level of evidence C recommendation. So not strong, maybe considered level C because all of those are retrospective analyses. But nevertheless, this is really quite a big change in the guideline to suggest that patients with an ejection fraction above 40%, at least some of them, should be considered for the treatments that we've used for some time in patients with HFrEF. So this is a considerable change, and I think this will evolve further. There's also an update on comorbidities. The one I want to highlight is the treatment of iron deficiency. We know already that improves symptoms, quality of life, and functional capacity. We did not know whether it reduced heart failure hospitalization or mortality. We've now got some new evidence that it does, and we've got that from the AFFIRM AHF trial published at the end of last year in Lancet. This was a relatively small trial, only 1,100 patients, a fixed, relatively short-term follow-up of only 12 months. So this trial didn't have the power to look at mortality, but what it did show us was that intravenous iron does seem to reduce the risk of heart failure hospitalization, as you can see here, by 26% in relative terms. So new evidence that IV iron is maybe doing even more for patients than we used to believe. And that has resulted again in a class 2A level B recommendation. This is a fairly strong recommendation. You should think about giving your patients intravenous iron if they're in hospital with worsening heart failure and are iron deficient, because we believe that will reduce their chances of readmission. So to finish with, I just want to mention something that was presented at the ESC that immediately meant that our guidelines were out of date. And in fact, on the same day, resulted in the ESC making a very unusual announcement, which was that the guidelines would be updated in 2 years' time instead of 5 years' time. Usually the guidelines go through a 5-year cycle, but the ESC has announced that they will be updated in just 2 years. And that's because of this trial. I suspect with the mention of Milton Packer's name, you may have already seen the results of Emperor Preserved, sister trial to Emperor Reduced, a trial randomizing patients with an ejection fraction above 40% to either empagliflozin or placebo. So I suppose we would have to call this today a trial in patients with mildly reduced as well as preserved ejection fraction. I'm not going to read through this in detail, but these were a lot older than patients in the HFrEF trials. Many more of them were women, 45% instead of 25%, as in the HFrEF trials, and lower EGFR, about 6 mils per minute lower than in the HFrEF trials. And as I'm sure you've heard by now, this 21% highly statistically significant relative risk reduction in the primary composite endpoint, although in this trial, unlike the HFrEF trials, the benefit was predominantly on heart failure hospitalization. That's still very important and still very valuable, but there was no significant reduction in cardiovascular mortality, which is a lot less common in HFpEF than in HFrEF. And finally, and just as importantly for this older, more comorbid population, this SGLT2 inhibitor was very well tolerated. You can see here very few imbalances between placebo and empagliflozin, very infrequent occurrence of ketoacidosis, just 4 cases out of almost 3,000 in the empagliflozin group. So we're going to learn more here. We already know from the Soloist trial that we can give these drugs to hospitalized patients across the ejection fraction spectrum. There's another big HFpEF trial called Deliver, due to report early next year. So that's why the guideline is waiting to see the results of this trial. So then we'll be able to do a very robust update in the next 2 years. So it could be very interesting. It may be that new guideline will have something to say about SGLT2 inhibitors in people with an ejection fraction above 40 and maybe even higher. So to summarize and conclude, the new guidelines take account of a lot of really exciting testing developments, both in HFrEF and to some extent in heart failure with mildly reduced ejection fraction. And then, as I've just shown you, we've got even more interesting and recent evidence about treatment for patients with heart failure and preserved ejection fraction. Thank you very much.
Thank you, John, for your excellent point of view about the pharmacological novelties in the clinical practice guidelines. We think that it's better to leave the discussion for the end of the presentations, of the 3 presentations that will be given in a row. So our next presenter is Marisa Crespo Leiro. She doesn't need any presentation here in Spain and even in most of the world. She works in La Coruña, and she will give her lecture on what's new in devices that we use for heart failure patients. Marisa.
Thank you very much, Javier, for the introduction. And I have to thank the organizing committee, especially Dr. Costello, inviting me for participating in this session. Dr. Costello asked me to speak in English so that Tini and John can understand me, but I apologize, first of all, because my pronunciation, as you will see, is far from perfect. So please forgive me. So I'm going to talk about what is new in devices for heart failure patients from the 2021 ESC heart failure guidelines. I'm trying to do that. So 2021 ESC guidelines, as already John talked about, is a extremely huge document with a lot of information, and it's my job to try to summarize what is the more important things on device. So first of all, heart failure treatment is complex and comprehensive. And that's why in the guidelines, we summarize that with a phenotypic approach in which there are room for drugs, devices, interventions, and multidisciplinary care. And of course, in devices, after the pharmacological, the 4 pillars treatment and treatment for congestion, there are important roles to reduce heart failure hospitalization and mortality for selected patients, and also for selected advanced heart failure patients are extremely important room for devices. First of all, pharmacotherapy is the cornerstone of treatment of heart failure in reduced ejection fraction, so it should be implemented before considering device therapy. And the goals for this is increased mortality, increased survival, increased quality of life, and decrease worsening heart failure and hospitalization. And these are the 3 main devices that I'm going to talk about: ICD, CRT, and mechanical circulatory support. First of all, in ICD, in secondary prevention of sudden cardiac death, there are no changes with the previous guidelines. So secondary prevention, ICD is recommended in those patients who have recovered from a ventricular arrhythmia causes hemodynamic instability and who are expected to have a good quality of functional status for over 1 year survival. And the primary prevention of sudden cardiac death, now there are a differentiation regarding if the etiology of heart failure is ischemic or non-ischemic. So in ischemic, and this is no changes regarding the previous guidelines, there is a recommendation class 1 level of evidence A that all patients after 40 days recurring myocardial infarction with LV ejection fraction less than 35%, despite at least 3 months of optimal medical therapy, and provided they are expected to have a good quality of life over more than 1 year. However, for non-ischemic, there are differences regarding the previous guidelines. So from 1 class recommendation now is class 2A recommendation. So in these cases, and these are in the beginning of the guidelines, probably you already noticed. On the left is the 2021 recommendation, and on the right is 2016. From non-ischemic etiology, came from class 1, now is 2A. And why is that? Probably there is in non-ischemic etiology better options for pharmacological therapy, and also what we saw in the Danish trial. So as already you all know that Danish trial was published near the 2016 guidelines, did not show a significant benefit in non-ischemic cardiomyopathy. However, subgroup analysis suggested benefit in those less than 70 years, and also meta-analysis suggests benefit in these patients. And also have to say that non-ischemic cardiomyopathy is a heterogeneous condition, and there are certain subgroups, genetic, for example, with laminopathies or sarcoidosis, we know that there are higher risk of sudden death. And also, we also know that there are scars on the magnetic resonance imaging that can show data from increasing risk of sudden death, and in the future, we can have more precisely select the patients who can be benefit from the ICD implantation. So, and of course, the ICD is not recommended in the patients who are within the 40 days of acute myocardial infarction, as implantation at this time does not improve prognosis. And also ICD therapy is not recommended in patients in your heart association class 4 with severe symptoms refractory to any pharmacological therapy, unless there are candidates for CRT, mechanical circulatory support of cardiac transplantation. And there are also special situations, patients who need a generator replacement. That patient should be carefully evaluated by the experienced cardiologist, joined with the electrophysiologist colleagues. In order not to directly replace the generator, we have to look for management goals, the patient needs, and clinical status that might have changes over the time. And also there is a role for the wearable ICD that might be considered for those patients who are at risk of sudden death for a limited period of a bridge to an implanted devices. Now we move on to the CRT. CRT, the two only class 1 recommendations in CRT is those patients who are in sinus rhythm, QRS more than 150 milliseconds, and L block morphology. And this is like in the previous guidelines. And also those patients who are needed for pacing for high degree AV block. For example, in this case, CRT rather than right ventricular patients is recommended in order to reduce morbidity. And this includes patients with atrial fibrillation. However, in the CRT, there are other situations which are 2A recommendations. The first one is those patients who are in sinus rhythms, QRS more or equal 150, and non-LVBB, that is no changes with the previous guidelines. However, in the patients who are in sinus rhythms with a QRS duration of 130 and 149 and LVB morphology, these patients had downgraded from 1 in the previous guidelines to 2A now. And also patients who had a conventional pacemaker on ICD and subsequently developed worsening heart failure despite optimal medical therapy, and who have a significant proportion of right ventricular patients, this should be considered for upgrade to CRT. So in the second, have been downgrade for the previous guidelines, as we can see, and in the third one, there is an upgrade from the previous guidelines from 2B and now from 2A. And also the patients who had QRS between 150 and 30 and 149, these patients had been downgraded from class 1 recommendation and now to class 2A. And this was based on meta-analysis studies. There are 2B indications when there are sinus rhythms, QRS 130 and 149, but non-LVDD morphology. And of course, and this is no changes with the previous guidelines, with the QRS duration less than 130 milliseconds, CRT is not recommended because we don't have indication for pacing due to high degree AV block. And in summary, this is the therapeutic approach for heart failure with reduced ejection fraction. And after the 4 pillars and the treatment on congestion, the decision for management, it depends on left ventricular ejection fraction, etiology, ischemic or non-ischemic, and QRS duration, and from level of yellow to indications to green class 1 indication. This is well very summarized in this algorithm. There are gaps in evidence. For example, there are indications for ICD in specific subgroups or heart failure mildly reduced ejection fraction or heart failure with preserved ejection fraction, and also optimal selection of ICD candidates in heart failure with reduced ejection fraction, including what I already talked about, ischemic versus non-ischemic cardiomyopathy. We need more research and CRT efficacy in atrial fibrillation, and of course, largest randomized clinical trials on cardiac contractility modulation and baroreceptor stimulation in heart failure with reduced ejection fraction, with now some interesting experience, but not too much data are needed. And finally, the mechanical circulatory support is the treatment in advanced heart failure patients. In these guidelines, there has been a new algorithm on advanced heart failure patients. Heart transplantation, as you can see here in green, remains the gold standard for the treatment of advanced heart failure in the absence of contraindications, because it improves survival and quality of life. And that's why it's the only class 1 recommendation in advanced heart failure. But long-term mechanical circulatory support have improved clinical outcomes, and now they are an opportunity either as a bridge to transplant or as a destination therapy when the transplant is contraindicated. So in advanced heart failure, pharmacologic therapy and short-term mechanical circulatory support might be needed until the implantation on long-term mechanical circulatory support or heart transplant becomes available. And for sure, the decision pathway to heart transplantation or either a long-term valve is never straightforward and is unique in each patient. And the use of mechanical circulatory support should be considered for the different scenarios, and the intermax profiles are very useful for accurately categorize the patient. And you can see here in the algorithm that patients in either intermax 1, 2, or 3 might be needing short-term mechanical circulatory support for decisions, bridge to decision, bridge to recovery, bridge to bridge another therapy, or bridge to transplant. For example, if a patient in intermax 1 can need a short-term mechanical circulatory support, and persistent in cases of severe brain damage or severe irreversible end organ damage, just we have to do is a withdrawal of mechanical circulatory support. But sometimes the cardiac, neurological, and end organ recover, and in this case can be willing for mechanical circulatory support. Sometimes neurological and end organ recover, but not cardiac recovery. In this case, we have to consider the patient for heart transplantation. If there is contraindication for heart transplantation, sometimes can be potentially reversible. That means that we can put LVAD as a bridge to candidacy. And if the contraindication reverses, the patient can be listed for heart transplantation with very close follow-up. Sometimes we need a long-term mechanical circulatory support to bridge to transplant. But if the contraindication does not reverse, the patient can be candidate for LVAD as a destination therapy. And always we have to carefully follow the patient, because even sometimes a patient who has been listed for transplant can be improved significantly. So sometimes advanced heart failure therapies can be referred, but with very close follow-up. So the short-term mechanical circulatory support or long-term mechanical circulatory support can be in these different scenarios: bridge to destination, bridge to bridge to candidacy, bridge to transplant, or bridge to decision. So regarding the short-term mechanical circulatory support, is an upgrade regarding the previous guidelines. Came from the 2B indication, now is 2A indications. Short-term mechanical circulatory support should be considered in patients with cardiogenic shock as a bridge to recovery, bridge to decision, bridge to bridge. And further indications include treatment of the cause of cardiogenic shock or long-term mechanical circulatory support or transplantation. Heart transplantation, as I already told, is recommended for patients with heart failure with class 1 level evidence C, always when do not have absolutely contraindication for that. And regarding the mechanical circulatory support, what we consider class 1 advice is that patients need to have good compliance, appropriate capacity for device handling, and psychosocial support. The survival trends with LVADs over time, new technology increases the survival long-term, and this figures show how is the survival with the latest trial, the Momentum 3, and regarding the survival at transplant at 2 years. However, the quality of life is hampered by compatibility problems with the LVAD regarding the transplant, so the quality of life is not so good at transplant. However, much improvement has been done. And now, destination therapy or bridge to transplant, in both we have 2A indications. In the destination therapy, there was an upgrade. Previous was 2A level of evidence B, and now it's 2A because we have more evidence, level of evidence A, and now also for bridge to transplant from previous 2A level of evidence C, now we have trials, and now it's considered 2A level of evidence B. The trial who was very important to define the usefulness of long-term mechanical circulatory support is the Momentum 3, which compared two types of pumps, the HeartMate 2, the axial flow pump, with the HeartMate 3, new technology, fully magnetically levitated centrifugal flow pump. And this pump had wide flow pathways, frictionless, and intrinsic versatility to reduce head stress and blood stasis. The 2-year follow-up results were published already 2 years ago, and the primary endpoint, the composite of survival period of disabled stroke or operation to replace or remove malfunctional device at 24 months, show a benefit from the HeartMate 3 versus the HeartMate 2. And they are very important. The principal safety outcomes in the per-protocol population analysis show that all hemocompatibility issues including stroke or bleeding problems or suspected or confirmed pump thrombosis, all were significantly reduced in the HeartMate 3 pump group. Very interesting and recent publication studying 2,200 HeartMate 3 ventricular assist device implants in the Momentum 3 portfolio, that including the 1,685 patients with continuous access protocol post-pivotal trial study compared with the pivotal trial patients with around 500. And showing the primary results that accumulating HeartMate 3 experience suggests a lower adverse event burden and similar survival. Indeed, a similar survival at 2 years was 81% in the CAP population versus 79% of the pilot population, in spite of being sicker patients in the continuous access protocol population, because there were more patients with intra-aortic balloon pumping and intermax-1 profile, and also similar 2-year survival in transplant ineligible patients, 79% versus 76%. So this is these beneficial outcomes in the patients after the pilot study are very encouraging results. Now there are challenges and concerns and considerations because still we have needs for innovation with LVAD therapy. We need reduce bleeding events with development of biocompatible surface devices. We need have the patient free from external power cables to fully internalized system with more comfortable and less risk of infections, and also more physiological and smart pumping to keep up with physical activity. And Dr. Mera, regarding these 3 rules of 3, very simple, advanced heart failure patients look for repetitive hospitalizations, 2 or more events in a year. Those patients who need increase in diuretic requirements to maintain the clinical stability, or those patients who start to developing no tolerance to hormonal therapy or cardiorenal perturbation. And we have to refer these patients in order to be considered either for an advanced heart failure therapy, first heart transplant, and second long-term mechanical circulatory support. So in summary, devices are an important component of the comprehensive and complex treatment of patients with heart failure. Pharmacotherapy is the cornerstone of treatment for heart failure reduced ejection fraction and should be implemented before considering device therapy. Indications and choices of devices for cardiac rhythm management, that means ICD or CRT in heart failure patients, take into account element ejection fraction, etiology of cardiomyopathy, and QRS duration. Short-term mechanical circulatory support should be considered in patients with cardiogenic shock as bridge to decision, bridge to recovery, bridge to candidacy, or bridge to transplant. And this is a recommendation 2A. And outcomes with a fully magnetically levitated long-term LVAD with HeartMate 3 have improved hemocompatibility issues, and survival is now around 80% at 2 years. And this is the recommendation 2A in the latest guidelines. And finally, and this is also in the guidelines test, health professionals are encouraged to take the ESC guidelines fully into account when exercising their clinical judgment, as well as in the determination and the implementation. However, the ESC guidelines do not override in any way whatsoever the individual responsibility of health professionals to make appropriate and accurate decisions in consideration of each patient's health condition and in consultation with that or the patient caregivers where appropriate and or necessary. And thank you very much for your attention.
Excellent.
Sí, yo. Sorry. Thank you very much, Marisa. Now we have to move on. Our next presenter is Tini Jarsma from Sweden. So it's a pleasure to have you here. And she's going to talk about what's new in nursing and organization of care in heart failure patients. Please, Tini.
Thank you. Thank you. And thank you, dear chairpersons and the Spanish Association for having me talk about this subject and not asking us to speak Spanish, because we probably would do a very lousy job and did not come further than hola and vino. That's all I know. Very important things. But I will talk about nursing and organization of care today for heart failure patients. And I will address these 4 aspects: heart failure management, patient education, telemonitoring, and palliative care. And just, you have seen this slide before, but what is really extra new, I think, is that we had 2 patients in the guideline in the committee. You see them here. And also, as we speak, a patient version of the guideline is developed now. So that will be, hopefully, ready in the end of the year. So that's really a new approach that the ESC takes. So I was just preparing this talk and of course I've been in a committee, but then I thought, how often is actually the nurse mentioned in the guideline? And I did search a document and it's 5 times and 3 of them are in the reference. So first I was disappointed, but then I looked, how often is the cardiologist actually mentioned in the guideline? And it's only 14 times. But the good thing is that the multidisciplinary is mentioned 30 times in the guidelines. So I think that is also a little bit changed, maybe in perspective. This is not about a professional or a person who delivers care, but it's really the multidisciplinary team. And luckily, the word patient was the most often in the guideline, which of course is not surprising. So heart failure management, and as you know, and it was in the previous guidelines, it is recommended that heart failure patients are enrolled in a multidisciplinary heart failure management program to reduce the risk of heart failure hospitalization and mortality. So what has changed? Well, since these 2016 guidelines, new studies have been published, and that underscore the need for this heart failure management program. So the evidence became stronger, but also reveal more details in how care can be organized. So it's not only replication of studies, but also exploring what is a good program, for example, and how can we adapt it to the current situation. We also know that our heart failure management program should be patient-centered and taking a holistic approach, which of course we all do. But what I like in the new guidelines is also that we say there that we should not only focus on heart failure management, but also manage comorbid conditions, so that the patient does not need to travel from a heart failure management program to a diabetes management program or a COPD management program. And you have seen this before, and I just blow up a little bit that it says to reduce heart failure hospitalization and improve quality of life for all patients. So indifferent of phenotype, an exercise rehabilitation and a multi-professional disease management program should be considered. And also in the acute heart failure figure, you see that in the follow-up, long-term follow-up after an acute heart failure hospitalization, also patients should be enrolled in a disease management program. And you also see it in different wording in the advanced heart failure. So what's also stated in the guidelines is that either home-based or clinic-based programs improve outcomes and are recommended to reduce the risk of heart failure hospitalization and mortality. And we do not say there that this one is better than that one, because it also depends a lot on local resources and of course situations like now in the pandemic. Our approach to heart failure management programs, virtual heart failure management programs, also have changed. And there has been a network analysis that conclude that both disease management clinics and home-based visits by nurses reduced all-cause mortality compared to usual care. And home visits have been found to be most effective. but no service model actually is consistently superior. So sometimes we feel that, or we find that home-based management programs are better than its disease management programs organized in the clinic, primary care. So there is a lot of developments, and like I said, it's also often depending on the healthcare system and local resources we all have. But it's not only how we manage our care from the hospital or the clinic, it's also about self-management, and that is also incorporated now in the guidelines that self-management strategies are recommended to reduce the risk of heart failure, hospitalization, and mortality. So really that patients are included in care, that it is essential, and it allows patients to understand what is beneficial, and also that they, for example, symptom monitor themselves and also can take actions. So if you then look at these heart failure management programs, what should be in it? As always, what is the best program? What's the most effective components? If we look at the 2016 guidelines, and I know this is small, but of course you all know it by head, there are some characteristics and there are components. And in the 2021 guideline, we have gone a little bit more in detail what is known that is effective, and we should add, and it should be patient or person-centered. It should really also focus on to have a big focus to facilitate, include patients that have to include symptom management, for example, prevention of the disease, prevention of getting worse, and also that people should monitor their symptoms. Also, and I have to read because I cannot read it here, encourage patient engagement and also include family members, and also to have psychosocial support. And we do that often, but now it's really targeted to really look at your programs. Do we do that? Do we have a structured way to do that? And also advanced treatment options, also what Marisa was talking about before. So heart failure management important, self-care important, and patient education. Patient education is vital. We knew that from the previous guideline, but in this guideline, what is really nice and good, I think, that we have a little bit more content on what is important in education. It's not only giving a flyer or saying you should do so and so, but really have new strategies, maybe use new strategies like Teach Back, to include family members, and also to recognize barriers in communication. So that is nice that we just added that, and also to edit the heartfailureMatters.org, which actually was also mentioned in the previous guideline as important, and we have now much more languages. What's also very nice in the new guidelines is that there's a huge table, I think it's 3 of the 218, about what should we educate our patients about, what is the goal for the patient to know all these things, and also what is our role as healthcare professional. So not just drop it in the lap of the patient, but what should we do? We should look at tools, we should look at our own behavior. And this is one of the tables. I will not go into it in detail, but you can really see how you can use that in your daily practice. There are several topics that got an evidence recommendation, and that is, of course, exercise and rehabilitation for patients. That has a 1A recommendation, and also to stimulate patients to get their vaccinations, which, of course, in this time is vital. I also would like to point you out to a document that was just published just before the guidelines. It's a self-care document of heart failure, where all these topics are given much more detail and actually say, what should you tell the patient and how should you tell the patient? Very short on telemonitoring. We're still trying out, of course, to find the optimal telemonitoring devices and approach, but in this guideline, it says non-invasive telemonitoring may be considered for patients with heart failure in order to reduce the risk of recurrent cardiovascular and heart failure hospitalization and cardiovascular death. And of course, in this time of COVID, the time of thinking green, the telemonitoring has received new attention. And another recommendation is that monitoring of pulmonary artery pressure using a wireless hemodynamic monitoring system may be considered also a 2BB recommendation. The last word on palliative care, also in this document, you find different places that the value of palliative care for heart failure patient is considered, that it in one part it says the palliative care and supportive care should be thought about for all patients with heart failure, regardless of stage of their illness. So don't think about palliative care in the end, but already have this approach of symptom management and quality of life from the beginning. And also that many patients actually should derive benefit from the early integration of a palliative and supportive approach by all members of the heart failure multidisciplinary team. And in the part also where Marisa talked about that patients in the advanced stages and those considered for mechanical circulatory support or heart transplantation should receive palliative care consultation before such an intervention takes place as a matter of protocol, not only because we think it's but really as a part of our protocols. So what's new? The multidisciplinary heart failure management is mentioned in the 15 key messages. So it's not something luxury we just do. It is one of the 15 key messages we take. The patient voice is clearly integrated. The self-care advices were updated and also extended. There's a more prominent role for telemonitoring, although we're still searching a little bit for the optimal approach. And also the palliative care approach in the heart failure trajectory is important. And with that, I would like to thank you for your attention.
Thank you, Tini, and thank you, and thanks to all the presenters for their excellent lectures. And since we are a bit short of time, we will go directly to the questions, some of them raised by the audience, I guess.
Yes, we have some questions from the audience here. The first two are for Tini. So if you can give us just kind of short answers. One of them is by nurses here in Spain regarding they did the randomized trial on titration of neurohormonal therapy in patients with heart failure, which demonstrated that heart failure nurses can up-titrate drugs safely. So we didn't see anything of that in the guidelines. What's your opinion, Tini, on this?
Yeah, well, and thank you for pointing it out, and thank you for publishing the trial. And as I said, the guideline is not about personnel. It's about patients. So sometimes it's nurses, sometimes it's cardiologists, sometimes it's general practitioners. So I think, and it's wonderful that nurses can take on this role, but it is about the patients and then finding the optimal practitioner to do so.
Perfect. Thank you very much, Tini. Also for Tini, we have a question from the audience. It says, many patients with heart failure are diabetics and older people. What type of flu vaccine do you think is better in these patients? Trivalent, tetravalent? I don't know if you know the answer. I personally don't.
I don't know the answer. I just would say get vaccinated, and I'm not a flu expert, so I would not say I don't know.
Thank you.
I don't think anybody knows because certainly there have been trials attempted to look at that exact question. For example, had to be stopped prematurely because unless you get the right flu season, you're not able to actually successfully test the hypothesis.
Okay.
Thanks, John. There's a question for you. In the new guidelines, there's a change in the main algorithm of pharmacologic therapy. In the 2016 one, we had a specific order of introduction of the main drugs, ICA plus beta blockers, and then if the patient is still symptomatic, mineral corticoid receptor antagonist, and then the other drugs. But now in this guideline, all the drugs are at the same level. I know you have strong feelings about the order of introduction of drugs, and we'd like to hear your opinion.
I don't really have strong feelings. I think what's collectively, so not just the ESC guidelines, but if you look at all the other guidelines and guidance documents published in the past year, I think there are probably two messages that come out. One is that what should be prioritized is the introduction of all of these treatments. They all work separately, different ways. Their benefits are additive. The benefits are seen quickly, and you get a lot of the benefit at a low dose. So what is now considered the priority is getting all of these treatments up titration, still important, but is now a secondary consideration. And then, as you say, there is no particular order to be preferred. So the order that we've traditionally used, starting with an ACE inhibitor, that sort of makes the assumption that somehow or another we've discovered the most effective and best tolerated treatment there is for heart failure first 40 years ago. And that's simply not a credible theory. So in fact, it doesn't really matter what order you start them in. I think I would rather focus on getting them all started as quickly as possible. We can argue, we probably don't have time today, about what might be the optimum way to do it. But maybe more importantly is not the order, but is getting them all started quickly.
Thank you.
Thank you very much. Marisa, I have a quick question for you. So the guidelines recommend mechanical circulatory support, but then we have different options of short-term mechanical circulatory support and long-term mechanical circulatory support, different devices, and not all of them have the same results. So do you think the guidelines should be more specific regarding what type of support we need? For example, the HVAD was just taken off the market recently. So I would like your comments on this issue.
Okay, yeah, thank you, Joe, for this very important question. Well, yes, the two third generation LVADs, long-term, the HVAD and the HARMATE 3, really in the momentum show better results regarding comparing the HARMATE 3 versus the HARMATE 2, and less problems with hemocompatibility issues. On June 3, the manufacturer of the hardware announced that they have decided to stop sales and distribution of its device because they had problems of device stop and start mechanisms, and which were sometimes associated with the deaths. And now the HARMATE 3 is the only one LVAD that is available for long-term support. And well, I think they are encouraging the results of the study that I mentioned, comparing the pilot data with the rest of the remaining patients enrolled. But we still need some improvements to reduce the driveline, the infections, and whether even the bleeding, and also the quality of life for the patient. So now I think there is only one, and it's easy to, no choice for the patient with long-term LVADs.
Excellent, Marisa. Thank you very much. Thanks to all the presenters and the audience for their questions. It's a pity we don't have more time for more questions, but it's been very interesting, and I thank you all. And please stay. In 5 minutes, there is another very interesting session on cardiogenic shock. Thank you.
Thank you.